Good evening to everybody from India and good morning to others joining from US and other parts of the world. Welcome to this edition of the IASNM Radiant Flashpoint Educational Web Series. And today we have an eminent nuclear medicine scientist, Dr. J. Mohan Roop. And for the benefit of some of the youngsters who may have joined, I have a gist of the very illustrious achievements of Dr. Mohan Roop. So he's a professor and associate director of nuclear medicine at AIG Hospitals in Hyderabad. He's one of the best nuclear medical physicians in Hyderabad, and maybe also in the country, possessing an extensive knowledge and experience in his field. And he graduated from Kurnool Medical College in 2009 and went on to do his MD in nuclear medicine from PG IMA, which is the Postgraduate Institute of Medical Education and Research in Chandigarh. Since then, he has been adding new horizons to his career, pursuing fellowships from renowned societies. A couple of ones I would list out for the benefit of the audience. He has received a fellowship from the Asian Nuclear Medicine Board in 2020, and earlier a fellowship from the European Board of Nuclear Medicine in 2019. He's also a certified radiation safety officer and certified in nuclear cardiology from EACVI in 2023. He has been an important part of various hospitals and organizations pan-India as a nuclear medicine physician. Among his long list of achievements, I'd just like to highlight one of them, which is actually the establishment of the Nuclear Department of Nuclear Medicine at AIG Hospitals, which is actually a state-of-the-art center providing comprehensive nuclear medicine services all under one roof. Dr. Mohan is one of the proficient and among the top nuclear medicine physicians in Hyderabad and holds special expertise in efficiently treating patients with neuroendocrine and prostate cancers. He is one of the very few nuclear medicine physicians who does PET-CT guided biopsy procedures, which is also going to be the title of this talk today. He has over 16 years of experience and has published articles in leading oncology journals and has maintained a very good academic record all throughout his career. He has personally presented many scientific papers, posters, and interesting cases at various national and international nuclear medicine events. He also has undertaken training in good clinical practices, GCP. His areas of research interest and expertise include interpretation and reporting of whole body PET-CT studies, interpretation and reporting of gamma camera imaging studies, low and high dose radioiodine therapy for thyroid disorders and cancer, PRRT therapy in patients with neuroendocrine tumors, radioligand therapy and targeted alpha therapy in prostate cancer, radiosynovectomy, bone pain palliation therapy in patients with metastatic bone disease, TAR procedures, PET-CT guided biopsy, and the automated robotic arm guidance. He also holds special interest in therapeutic nuclear medicine, multimodality, hybrid cardiac and oncology imaging with PET-CT and PET-MR, PET-CT guided biopsy and automated robotic arm guidance, novel image processing techniques, including quantitative imaging. He has numerous accomplishments and had also been awarded the Silver Medal, which is Merit of the First Order for overall performance during his nuclear medicine residency at PGIMA. He is also a member of the Radiological Society of North America, American Society of Nuclear Cardiology, Society of Nuclear Medicine Molecular Imaging from US, Society of Nuclear Medicine in India, and also holds a membership in the Association of Nuclear Medicine Physicians of India. Today, he is going to talk on PET-CT guided biopsy, a revolution in precision medicine. And without further ado, look forward to a wonderful session from you, Dr. Mohan Roop. Over to you.
Thank you, ma'am. Thank you for the introduction. Yeah. So, hi, good day to all. So, before going into the topic, I sincerely thank Dr. Josna ma'am and Dr. Saima ma'am for giving me this wonderful opportunity. So, I'll be discussing about the PET guided biopsy, how it is making revolution in the precision medicine. So coming to the agenda, I'll be discussing few points about the basics of biopsy, its benefits, limitations, how the PET-CT integration can help in improving its accuracy, and the topic of interest is PET-CT guided automatic robotic arm assisted biopsy, its advantages, disadvantages, and few of the cases, like difficult cases that we have performed at our center. So whenever a clinician suspects any lump in the body, he'll advise few investigations which are basic like ultrasound, CT, and coming to advanced like MR and PET-CT. So with the help of these investigations, we make a differential diagnosis. But the major question is whether these differential diagnosis is enough for treating the patient. We all know that it's not sufficient. So we need a proper pathological diagnosis with IHC for treating the patient. Just a minute. So for having the definite pathological diagnosis, a biopsy is must. So coming to the biopsy, there are different kinds of biopsy like incisional, excisional, and the needle biopsy. We'll be discussing in detail about the needle biopsy. So incisional biopsy will give a small incision and a small sample of the abnormal tissue will be taken out, which is sent for the pathological diagnosis. In case of excisional biopsy, the entire lump or the lesion is removed. As we are removing the entire lump, it is more of an invasive procedure. So sometimes general anesthesia might be required. As general anesthesia we are administering, so sometimes hospital administration might also be needed in such cases. So it's kind of cumbersome to the patient for excisional biopsy. So coming to the needle biopsies, here a thin needle will be inserted through the skin puncture to the target tissue, and we take a piece of or the chunk of abnormal tissue from the desired site. So coming to the needle biopsies, we again have two types. One is FNSC, one is core biopsy. In case of FNSC, we'll use a thin bore needle. So through the thin bore needle, we either aspirate or suck few cells or the fluid from the desired lesion. Whereas coming to core biopsy, we'll use a relatively larger bore needle. Through the larger bore, we'll get a relatively big chunk of tissue. So as we have a good chunk of tissue, we can perform IHC and further studies on this core biopsy as compared to FNSC. So there are various kinds of image guided biopsies such as ultrasound, CT, fluoroscopy, MR. So coming to their benefits, we know that we get a definite pathological diagnosis with the help of these imaging modalities, targeted biopsies. These are reliable methods, kind of less invasive, so they become less painful. As less invasive and less painful, we have shorter recovery time and they have fewer complications. So these can be performed on outpatient procedure basis. So out of all these imaging guided biopsies, CT is the most versatile thing, or the CT guided biopsy is the most versatile one, and which is commonly performed. It follows ultrasound guided biopsy. So here we can target both superficial as well as deep lesions, but the diagnostic yield or the performance of CT guided biopsy varies like based on the kind of lesion, presence of viable tissue and non-viable tissue within the lesion, presence of significant necrosis, or we are having adjacent consolidation, particularly in case of lungs, or if we having post-RT cases, whether adjacent fibrosis will interfere with the insertion of needle or not. And it also depends upon the target organs as well as the type of needle that we are choosing for the biopsy. So coming to its limitations, we can have like inconclusive or the inadequate sampling. Sometimes we have false positive, false negative findings. And based on the position of the lesion and whether it is situated deep or behind major vessels or in close relation to the important organs, sometimes on CT, we won't be able to properly make safe access route to reach the target lesion. So it becomes very difficult to do biopsy in such cases. And as I already said, it is very difficult to differentiate between viable and non-viable portion on CT scans. So coming to contraindications, these are common for all image-guided biopsies. So presence of non-cooperative patients makes doing biopsy very difficult. Presence of altered coagulation profile, which needs to be corrected before going for the procedure. So we have many limitations. How to overcome all these limitations such as false positives, negatives, inconclusive results, having technical problems to insert the needle to go to the target site. Other limitation being performing repeated biopsies, particularly in difficult cases, which might lead to increased time, cost, and morbidity to the patient. So to overcome all these limitations, we can have, or there is a single possible solution, which is PET-CT directed or the guided biopsies. This is the new innovative approach where we'll be inserting the needle particularly into the metabolically active or the viable area, most metabolically active area, from where we take the sample. So automatically it improves the accuracy and the diagnostic yield of the sample, thereby reducing the chance of having a repeat biopsy, and it is cost saving to the patient as well, and it enhances the clinical decision making, as well as decision can be taken rapidly, because first time as we direct biopsy from the active area, we'll get a positive sample immediately, so decision can be made as rapid as possible. So coming to the PET-CT guided biopsies, we have 4 ways to perform the PET-CT guided biopsies. One is doing a pre-procedural PET-CT, where the PET-CT is reviewed and it is retrospectively fused with other imaging modalities, and at the time of biopsy, so this fused PET along with intra-procedural CT will help in guiding the needle positioning. So second method is using a real-time PET-CT guided biopsies, but the needle is inserted by performing serial check scans during the needle insertion to finally check whether the needle positioning is proper or not. In the third way, we have a real-time PET guided biopsy, which is fused along with other modality, which is fluoroscope for placing the needle, followed by serial CT scans to see whether the CT is whether the needle is in the perfect position or not. And the most recent and the advanced, effective and safe method is the robotic arm assisted PET-CT guided biopsy, which I will be discussing. So we all know the phrase, well begun is half done. So proper patient preparation and planning is very important for any procedure to increase its success rate and have lesser complication rate. So coming to patient preparation, we need prior preparations before the day of biopsy and few preparations on the day of biopsy. So coming to prior preparations, most important one is fasting. We know for all FDG PET guided biopsies, fasting is necessary. And if there is any need for sedation, or if there are any unforeseen complications where intubation or other interventions are needed, for all these purposes, fasting is necessary. So 6 hours of fasting is must. In like this can be reduced, particularly in diabetic patients who can have a light meal in the early morning. But minimum of 4 hours fasting is must for any invasive procedure. So coming to medications, these people can continue antihypertensive, hyperlipidemics, and other routine medications. Coming to anti-diabetics, if the biopsy procedure is scheduled along with the diagnostic PET-CT on the day of on the same day, anti-diabetics have to be skipped. But if the procedure is scheduled at an alternate day or the subsequent days, so these medication can be taken on the day of biopsy procedure, as it there is a little bit of interference, very minimal interference with the uptake. So which will be planning the trajectory based on already pre-acquired PET-CT. Coming to drugs which need to be stopped, so we know aspirin, NSAIDs, antiplatelets, all these have to be stopped for at least 3 to 5 days. So there is no indication for routine use of antibiotic cover if you follow the strict like aseptic precautions. Coming to investigations which need to be performed, or hemogram, coagulogram, and the viral markers. I'm not going into detail about the hemogram and the coagulogram, their limits, how to correct them, all those things. So these are the necessary investigations. And once these are within the limits, we can go ahead for the procedure. And if there are beyond the limits, or if they are abnormal, we need to correct these things first and then go ahead for the biopsy. So coming to viral markers, if they are negative, good enough. If they are positive, we should take proper precautions to avoid contaminations or to avoid contacting the disease. So all these tests should be obtained within 48 hours before starting the procedure. So coming to on the day of biopsy, we need to assess the general condition of the patient. So how he is, how conscious level, whether any comorbidities are there for the patient or not. So all these factors are important to see whether there is any need for sedation, And at the time of positioning, if the patient is having any comorbidities or the joint pains or some other issues with lying down in a comfortable position, it will be difficult to do the biopsy. And once the positioning is done, we should ensure that patient is able to cooperate during the entire procedure in that comfortable position. So coming to vital signs, all these vital signs have to be assessed and they have to be documented. So these pre-procedure vital signs, documented vital signs, will be compared with the post-procedural vital signs like blood pressure and pulse rate to like pre-assess any complication that is going to come in the patient. If the pulse rate is increasing and BP is falling, we can assume that there is internal bleed and immediately we can take necessary measures. So coming to the review of the latest investigations, as I already said, the hemogram, coagulogram, which are done within 48 hours, we'll be reviewing them and correcting if there are any necessary measures to be taken. And other related radiological investigations which are performed have to be reviewed. We have to see whether there is any progression or resolution of the disease. If there is any resolution, we'll automatically postpone or abandon the procedure. Coming to pre-medications, like these medications we give based on patient-to-patient basis, analgesics, antipyretics, and antiemetics. And we need to check few equipment whether they are ready and they are in the proper working condition or not. First one, as we are doing automatic robotic arm, we need to check whether the robotic arm is properly calibrated or not and properly functioning and properly docked at the proper place or not. And we need to check BP apparatus, pulse oximeter, availability of oxygen cylinder, trolleys and wheelchairs as and when emergency basis required. Another important prerequisite is the patient consent. We need to see patient is competent enough and coherent that he is able to give an informed consent to us. If he is adult, he will give consent by himself. In case of children, we'll take the consent from parents or the caregiver. And we need to see whether he is making a voluntary decision to undergo the said procedure or not. So once we come to the PET-CT guided biopsy, so first important factor is the dosage, amount of FDG that we are going to inject to the patient. So for diagnostic PET-CT, we'll be injecting around 6 to 8 millicurie. And for if we are planning only biopsy, we can inject 1 to 3 millicurie, which is sufficient enough to see the active area and which is at a lower border level, so that the amount of radiation dose that the patient uh, uh, as well as the performing consultant will expose to the radiation. So to reduce that radiation, we have to inject as minimal as possible. Once we inject 3 millicurie, 1 to 3 millicurie, after 60 minutes, we acquire around 1 bed position of the desired site for PET guided biopsy. If you are planning the PET guided biopsy along with the whole body PET CT, so we'll be injecting around 6 to 8 millicurie. We'll be acquiring the whole body scan and we give around 2 to 3 half lives to reduce the dose to as minimal as possible, followed by we'll be performing the procedure during the afternoon. If you are injecting in the early morning, we'll be scheduling the biopsy during afternoon with the same single dose. So coming to the biopsy set, we need to make sure that all these items are available within the biopsy set. First is antiseptics like codeine iodine solution for cleaning the point of entry or the site of biopsy. Second one is the analgesics, 2% lignocaine for local anesthesia. We need to have the dressing material. We need to have the needle, surgical blades, surgical scalpels, gloves, and the biopsy guns. So coming to the automatic robotic arm, so as I already said, it needs to be properly calibrated, properly connected to the PET-CT so that transfer of images happens from the PET-CT into the robotic arm, and the docking has to be done at the perfect place. We have docking plates on two sides of the patient couch. We have on the right side as well as left side. Based on the site of lesion in the patient, we'll be docking the robotic arm at the either right side or the left side. This has to be done in a conscious and proper way so that we won't be entering the opposite side of the patient. So if we are having a lesion on the right side and if we are planning to go on the right side, if it is closer to the central area, we can dock either right side or the left side. But if it is towards the periphery, we have to dock on the right side. So accordingly, we should decide and dock the machine prior, so that we won't waste sufficient time at the time of patient positioning. So this old one is the Robio, and this is the new one, which is the Maxio. The advantage of Maxio over the Robio robotic arm is we can do 3D angulation planning at the time of trajectory planning, so that we can have craniocaudal angulation as well as mediolateral angulation. All these angulations can be planned ahead before starting the procedure. So coming to the overall procedure, the first important step is the patient positioning and immobilization. So patient can be positioned in supine, prone, lateral liquitus with flexed legs, with extended or the elevated arms, with kind of a anteriorly bent spine, or whatever the position which is helpful for us to plan the safest trajectory. As well as this position depends upon the localization and the size of lesion. If it is situated posteriorly, we'll ask the patient to have a prone position. If it is more towards anteriorly, we can have a supine position. So in that way, we can plan our trajectory. And always we should plan the trajectory in such a way that first thing that we need to keep in mind is safety of the patient. So we need to avoid all the vital structures when we are planning our trajectory. Second thing, when we are planning our trajectory, is the trajectory should be as small in length as possible, so that we avoid little amount of tissue within the body. Third thing is patient cooperation and comfort. So the position should be such a way that it has to be comfortable to the patient, and he will be able to cooperate in that position throughout the entire procedure. So coming to the patient positioning and immobilization, this is a vacuum assisted device which is placed on the surface of the couch. So over that the patient lies down, and this is wrapped around the patient, and the only biopsy site will be exposed outside. And with the help of a vacuum machine, so this will be made hard and the patient will be immobilized in that position. So coming to the second step, which is acquiring the one bed PET CT of area of interest. Here, as we are injecting low dose of around 1 to 3 millicurie, PET is acquired over a period of 2 minutes. And then CT, we need to acquire in thin slice, at least minimum of 1 mm thickness. So coming to the next important step, which is trajectory planning. As I already said, based on the position of the lesion, we need to position the patient, and then we need to plan the trajectory. So safety has to be kept in mind, followed by the path or the length of the trajectory. And the third one is the angulation. All these three things are to be kept in mind. So here, once this data is acquired and all this is entered, transferred to the robotic arm, it automatically gives us the target depth as well as any of the angulation that is there or not. So here, so for this lung nodule, we have planned the trajectory from the skin surface to the lung nodule through the mediolateral approach. And then once the data is sent, it is saying that around 56 mm is the target depth from skin surface to the target, so which is around 5.5 centimeters. And here the point of entry and point of entry into the target, skin entry as well as point of entry into the target, are at the same axial plane. You can see both are at the same CT frame. So that is why craniocaudal angulation is 0 degrees. Sometimes if there is any bony structure or any vital structure is there in between our point of entry as well as the target, we need to adjust these angulations, which automatically robo can keep in mind and suggest our trajectory. So once all this data is entered and once we hit the position button on the robo, so automatically the arm positions over the surface of the patient where the biopsy is planned. So once it is positioned, we need to keep this bush adapter attached to the arm. So towards the end of the bush adapter, we'll keep the bush. Bush is nothing but these two leaflets which are attached together. So once we insert this bush into the bush adapter, we'll clamp the bush adapter. So once it is clamped, that means it is fixed to the bush adapter. It doesn't move. So once it is fixed, then we'll pass the coaxial needle through the bush adapter, and we need to take the sizes of bushes such that if the size of the needle is around 18 gauss, then these bush adapters have to be at a lower number size, so which is like 16 and 17 gauss, so that the diameter of the hole of the bush is not too tight or not too loose for the coaxial needle to pass through it. We pass the coaxial needle, and once the needle touches the skin surface, then the laser arm will be activated. That laser arm will project the laser onto the skin surface. So that exact point of laser projection is the actual site of entry. Then we need to match whether the needle tip and the laser projection are matching or not. Once both are matching, then we can go ahead with the procedure. So once the entry site is confirmed and the laser projection is made onto the skin surface, that area is inspected to see whether there is any local infections, any superficial dilated superficial veins, any pulsations of underlying vessels, or any other bony landmarks are there. To avoid those things, we have to palpate the skin surface. So once that is done, we'll communicate with the patient that we'll be inserting the needle, and before that, we'll be disinfecting the site. So we'll take gauze piece dipped in povidone. We'll disinfect from center towards the periphery in centrifugal manner. Once the area is disinfected, then we'll do a local anesthesia injection at that site. We'll take a 10 cc syringe filled with 2% lignocaine, and then we'll insert the needle in till the depth that it reaches skin, subcutaneous as well as superficial muscles. uh, we'll be injecting the anesthesia slowly, and while withdrawing, we'll be slowly injecting and withdrawing, both doing at the same time. If we are planning for a lung biopsy, this local anesthesia has to be infiltrated till the level of pleura. If you are planning for a bone biopsy, till the level of periosteum, and if you are planning for any solid organ like liver, the capsule has to be infiltrated. Once we infiltrate and remove, we need to wait for 1 to 2 minutes for its starting of action. So after that, we give a small stab incision at the site of point of entry, and then we have to carefully check the stab incision wound to see whether there is bleeding happening at that time at that place or not, and whether the bleeding is taking significant time to stop. If it is taking significant time, that means there is some bleeding diathesis in the patient, so we need to terminate the procedure. So once we take care of all those things, then through the stab incision, we'll be inserting the coaxial needle with least point of resistance, as we have already given the incision over the skin surface. And this will be inserted in step-by-step manner in small increments. So you're able to see the markings on the coaxial cannula, right? So each marking is around located at a distance of 1 centimeter. So you can see that these are thin markings, and we have a thicker markings at two places. So we have thin markings at 1 centimeter distance, and for every 5 and 10 centimeters, we have thicker markings for easy identification at the time of procedure. So as we have already seen during the trajectory planning, that target depth is around 5.5 centimeters, right? So this is around 5 centimeters, this is around 6 centimeters. So keeping that in mind, we'll be inserting like to the half of between these two lines, and we can assume that the needle tip is exactly in the target lesion. So once we go in like in the small increments till the desired level, so we'll take a check scan, then see whether the needle tip is perfect or not. I'll show an example. So we are able to see a small metabolically active nodule in the basal segment of the left lower lobe. So patient is kept in the prone position because the nodule is situated in the posterior position, and through the posterior mediolateral angulation approach, we are going into the needle. So we did a check scan in between to see whether the trajectory is maintained or not. And this is the final check scan where you are able to see that the needle tip is exactly within the target lesion. So once the needle tip is exactly in the target lesion, we'll remove the sharp stylet from the coaxial cannula, and we insert the biopsy gun. So this is the tip of the biopsy gun. You are able to see the trocar, and this is the outer cutting cannula. So trocar will be having a small defect, and once we push the this I am speaking regarding the semi-automatic gun. This trocar will be inserted manually into the target lesion, and once we hit the biopsy button one, so this outer cutting cannula moves inwards, and the tissue between the cutting cannula and the trocar will be trapped here. So which is nothing but the final biopsy sample. So these samples we can take sizes of around 1.5 and 2 centimeters. So one, and depending upon the position of the coaxial cannula, we need to position our trocar in such a way that it has to be facing most of the target lesion, so that we will get very adequate sample. See, for example, if this coaxial node cannula is towards the periphery of the lesion, towards the right lateral aspect, we have a normal tissue. Towards the left lateral aspect, we have the abnormal tissue. So now the trocar should be facing the left lateral aspect, and will be hitting the gun, so that this tissue will be trapped within the gun, not rather than the normal tissue within the gun. And we need to take adequate sampling. We can take all the areas like superior, inferior, superolateral, inferolateral, superomedial, and infromedial, all these areas. And these sample will be collected in either formalin or the saline container. So this is the formalin container, so saline container. So you can see the sample tissue. The sample collected in the saline container will be sent for microbiological and cultural purposes, whereas we collect the sample in formalin sample, so particularly for HPE, IHC, and all the mutational analysis markers. So once that is done, we'll again do a check scan to see any of the complications. Finally, this sample along with the pathology request form, including all the details of the patient, the clinical condition, and the imaging details, as well as the specific tests needed, along with our signature, will be sent. So let me walk you through the entire procedure once again for better understanding. I'll be brief and fast. So first we'll review the PET-CT scan, then we'll have the patient positioning and immobilization. Once that is done, we'll do a preliminary desired scan of one bed position of the corresponding area. Then we'll access the path or plan the trajectory. Once the trajectory is planned, we'll project the laser projection onto the skin surface. At that site, we'll make a marking on the skin surface. Marking is done, we'll be inserting the bush adapter, bush, coaxial needle. Before inserting the coaxial needle, we'll be doing the antisepsis and local anesthesia of that area, and we'll insert the coaxial needle. And exactly at the tip of the coaxial needle, we'll give a small incision through which the coaxial needle will be inserted for the desired length based on the target depth given by the robo arm. And once it is inserted, we'll do a check scan to see whether tip of needle is exactly within the desired area or not. And we'll remove the sharp stylet, we'll insert the gun, we'll take the biopsy from that area. So once a biopsy is taken, we can do a check scan to assess the technical success of the biopsy procedure. Because whenever you remove a tissue, you create a small air pocket at that site. You can see in the check scan whether these air pockets are within the desired site or not. And followed, once you are confirmed that you got adequate sample, you will remove the coaxial and the gun as well. And then you do the local antisepsis again along with the bandaging of the puncture site. Then we'll do a post-procedural check scan to look for any complications like bleeding, pneumothorax, and all the other complications based on the target organ that we are inserting. So coming to the post-procedural care, patient will be kept under observation for around 2 to 4 hours. Then we'll do a serial X-rays to see. Then we'll be monitoring the vitals to pre-assess or to foresee the complications. Then we'll use appropriate use of other medications like analgesics based on patient-to-patient basis. Coming to important considerations which we need to keep in mind. So first one is maintaining aseptic precautions during the entire procedure. We should absolutely adhere to the coagulation parameters to avoid bleeding risk. and then we need to plan our trajectory such that it is the safest and shortest path, and we need to have adequate sampling so that to avoid repeat biopsies in future, and the sample is sufficient for various profilings. And then finally we'll be doing a check scan and releasing the patient. So coming to the advantages, as we have seen, it's highly practical and useful, particularly in patients with previous inconclusive biopsies and in targeting the metabolical indeterminate lesions and all these viable, non-viable areas, mass, consolidation, recurrence, fibrosis. All this information will be getting from PET. Robo will be helpful, particularly in planning the trajectory such that we'll be going through areas, avoiding all the major structures, major vessels, and we can insert the needle with very high confidence, and with a single stroke we can directly enter into the target lesion without having all these analysis in our mind, all these things calculated by our mind. And even we can do manually once we are very highly experienced, but whenever the lesion is very small, if it is less than 1 centimeter, or if it is situated at a places which is very difficult to access, even with our experience we won't be able to target these lesions with very high confidence. So particularly in these places, this robotic arm will be very helpful to get very good accurate sample from the lesion. So coming to disadvantages, very few disadvantages, but these are very important. One is financial feasibility because the cost is high. Like once the volume of these procedures increase, maybe we can reduce the financial cost of these procedures. And all the centers will be having a single PET CT where the volume of PET CT scans will be very high. So if you are planning a biopsy in between, it will hamper the department workflow because we know that FDG is having a half-life. So all the time which is taken by the biopsy will matter. So coming to sites like at the lower lobes of lungs and at the sites of subdiaphragmatic level of liver biopsies, we have the respiratory cardiac artifacts which may cause the registration error, leading to sampling errors when we are taking from particularly these sites. So other considerations that we need to keep in mind is the amount of radiation burden to the patient and the exposure that the clinician who is going to perform the biopsy. So we need to inject as minimal as possible, and we schedule our biopsy at a sufficient time after the injection, so that we have sufficient counts and as minimal radiation to us as possible. So I'll show a few of the cases where how this automatic robotic arm was helpful, particularly in having a very good sample in these cases. First one is a case of carcinoma rectum with a very large liver SOL. You are able to see all the center area is necrotic and there is only very thin rim of periphery. So this was particularly helpful so that needle tip is exactly within the metabolically active site, and then we are avoiding all the major vessels of the liver. We are going to the periphery of the lesion, and we got a very good sample. Particularly came as a final HPE came as metastatic adenocarcinoma. So here I'll show the trajectory. So you're able to see the needle with needle tip exactly within the lesion. So the sample was very good. Second case, which is a suspected case of carcinoma pancreas. Patient was known chronic pancreatitis with multiple calculi, and because of weight loss as well as elevated CA19-9 levels, pancreatic malignancy was suspected, and PET CT showed the mass. Here, the gastroenterologist was not able to do the biopsy from the lesion because of extensive calcifications and adjacent vessels. So we took this challenging case for robotic assisted biopsy. We took a path going through the omentum below the stomach. There was a small path going through the left lobe of liver, but if we go in a single poke manner without multiple insertions and withdrawals, we are confident enough that there won't be sufficient bleeding or other complications arising out of it. And finally, we were able to target the mass and then we got the pancreatic ductal adenocarcinoma as the HPE. So another case, this is a case of ampullary adenocarcinoma. On follow-up PET CTs, we were able to see very small 9 mm nodule in the apex of left lobe. So this very small 9 mm nodule, if we go with the manual approach, we have trial and error methods. Every time we'll insert the needle, we have to do a check scan. We see whether the needle is exactly in that site or not. We have to do again. So we have to do multiple times. So patient was having kind of a mild emphysematous changes as well. So to reduce the complication risk of pneumothorax, we took the robotic arm assistance, and with a single stroke, we directly entered into the lesion and took the sample, which finally turned out as metastatic adenocarcinoma. This is another area where the robotic arm was particularly helpful. You can see that this is a case of C rectum post surgery, and there was a metabolically active area along the left levator ani muscle, so which was close to the coccyx almost. So with manual planning, it was very difficult to enter such sites. So with the help of robotic arm, we were able to angulate our trajectory so that if we go at a perpendicular fashion to the lesion, and if we are overshooting the gun, we'll be injuring the adjacent organs, and because of overshooting, we'll get a tissue which is outside the metabolically active place. So we have inserted the needle in such an angulation that once we overshoot the gun by around 1 centimeter, we'll get an adequate sample from the metabolically active site. This was very challenging case, and finally turned out as metastatic deposits of adenocarcinoma. So overall, we have done around 81 procedures, which included varied sites within the body, and with around 98% accuracy, we have performed all these procedures. So the take home message is this is highly practical and particularly useful in patients who have previous inconclusive biopsy, and doing biopsies from deeply seated lesions at abnormal anatomical locations if the lesions are very small, and as I already said, viable, non-viable, necrotic, non-necrotic, to differentiate mass, and all those are routine things which can be done with the help of PET CT itself. But the arm will be particularly helpful. But just a minute. So it will be particularly helpful in targeting lesions which are situated deep, as well as to target a smaller lesions with more confidence level. So as Benjamin Franklin said, by failing to prepare, you are preparing to fail. So the proper patient preparation and planning is must to increase the success rate of any procedure. Thank you.
Thank you, Dr. Mohan, for that very lucid presentation. And the session is now open for discussion.
Hi, my name is Narendra Gupta, and I do thoracic biopsies. I have millions and jillions of questions, but I would keep it very short kind of thing because I do. So, Dr. Jayanthi, that was a very lucid presentation, and there is every day is a new learning phenomenon. So, couple of questions, or maybe 3 or 4 questions, time permitting, but in-body people can jump in, because I have so many questions. I can go on for an hour because I do the biopsies almost every second day. So how much is the cost of you said there are 2 machines, the older machines and the new machine.
Yes, sir.
What is the Robio and Maxio you mentioned? What are the cost of these?
I can't disclose the exact cost, sir, but it is around 40 to 50 lakhs for a Robio and around 80 to 90 lakhs for a Maxio.
80 to 9. And okay, so that brings to another question. When you are co-registration is fine, you can have your images at different times and then target your lesions accordingly. But when you are going to do real time, when you inject your FDG kind of thing,
Yes.
low dose FDG, how much you inject around 2 to 3 millicurie, that's what you said. And
Yes.
normally for your diagnostic scans, you wait 60 minutes to get your PET CT images. But for biopsies, how long do you wait, and what is your optimal time of waiting between the injection and acquiring the images and setup?
So we are taking around 90 minutes to around 120 minutes, sir. Uh, because taking out 1 to 2 millicurie from the concentrated part was very difficult for our technologists. That is one of the factor at the time of injection. So whenever they withdraw, at least we get around 2 to 3 millicurie. So with even 1 millicurie, we can acquire we can go ahead with the procedure at 60 minutes. And if you are injecting around 2 millicurie, we are scheduling at around 90 to 120 minutes. Yeah, that is the ideal time that we are following, sir.
No, I would say, hi, audience. I would say I don't want to hog in everything. I can go for 2 hours on this. I have so many questions because I do it. The other thing I just wanted to know is what is the and I'm going to restrict myself to the lungs and mediastinum to the thorax. That's what my expertise is. What is lung nodules? How now? I mean, say IP people can reach almost everywhere. Interventional pulmonologists. They can hit with the electromagnetic and other techniques, to any
Yes.
nodules, which when they don't get samples, those cases come to me kind of thing. Oh, look, we didn't get any positive samples to that. Can we try now CT guided biopsy or something? So what is your minimal size you will accept? And that brings to minimal size. The example you showed, one in the right or the left apex, that was easy peasy, 9 millimeter kind of thing, not much movement. But if it is the same lesion near the diaphragm, where it is doing a robo dancing kind of thing, with the respiration, how do you tackle those kind of thing?
Sir, once we see that if the co-registration is happening perfect even at the lower places, so we feel that there is little bit of movement because like at the time of CT as well as PET acquisition takes around 2 minutes. So even with a 2 minute interval, if the co-registration is perfect, we feel that we can target even less than 1 centimeter lesions. But once we acquire PET CT and we are seeing very high movement at the lower places, again, we need our manual thing or the experience which need to be taken into consideration and whenever we are targeting such lesions. So in case of lower lobes, we have targeted around 1 centimeter lesion. That is the smallest one that we have targeted, sir. We didn't go beyond like lower limit of 1 centimeter as of now. So as I already said, I did only around 26 cases of lung CA. So I need to see in further how I'll be able to tackle this problem, sir. Yeah.
Maybe I need to visit you because I haven't done any. I'm saying we don't use robot, but we do burn them with cryo and microwave, sometimes, and that's where we use the robo, but not for the biopsies. For the biopsies and insertion of the needle, I use fluoroscopic, real time kind of thing, with aspiration.
Oh,
And so Dr. Jayanthi, when you use sedation, and you mentioned something about Tylenol or the paracetamol injection, and do you give them sedation during lung biopsies or uh, what kind of sedation? I'm saying I prefer to give only painkiller kind of thing rather than using any temazepam or lorazepam or something highly sedative, because
no,
once.
sir. Yeah, we are also not giving, sir, because again, it has its own complications, and if the patient is not responding, we don't know whether because of the sedation or because of the complication. We are also going ahead only with the analgesics as well as local anesthetic drugs. Other than that, we are not going for any other strong sedatives, sir.
No, that's what, and what's your, I mean, so you said your success rate is 98%, 97, 98% approximately, that's for every lesion. I mean, so some of the lesions were pretty big, like some 3
Yes.
centimeters. So that I can hit the blind-eyed kind of thing, with one eye, so I'm saying, because we don't get anything less than 1 centimeter, because most of our IP people. But that's a wonderful, there was some message for me. I don't know, I haven't read it. What was that message? You have to attend IASNM dinner. We have been missing your presence for long. Oh, okay. All righty. That's from Chitra. Uh, no, thank you. I would say, and I'm coming to Hyderabad next year. Maybe I will touch base with you, and you can take me through some of the biopsy procedures. But no, thank you so very much. It is an eye opener, the patient safety and everything. I really appreciate it. And thank you, Dr. Krishnan, and thank you, Dr. Takalkar, to arrange these wonderful sessions.
Thank
Gupta
you
ji,
for
thank you.
Thank you.
There is a question also from Dr. Raghuveer Krishna Halkar on the chat box. It says, thanks for a well-organized, great talk. How much additional charge in India? I'm just reading it.
So at our place, CT gated biopsy is around 25K. So we are adding a 5K additional charge for the FDG that we are going to inject. So it's little bit higher, but it's okay. If you are going for a patient is going for a re-procedure, or if you are going as this as the first attempt to the patient. So we are counseling the patient accordingly so that the sampling error is very less. So it is justified in charging little bit more as compared to city-gated biopsy.
Dr. Jayanthi, another question. I mean, say, if I may have your phone number in the chat box, that would be great. Otherwise, I can find you. That's not because I have so many questions and I don't want to hog into the whole discussion.
Gupta ji, we'll share the phone. We'll share his contact information.
That would be great. Thank you, Amol,
Thank
because
you.
I want to learn this and the other thing, from start to finish, putting the patient on the table. How long do you take for a lung biopsies for a 1 centimeter lesion?
Yeah. So initially in the learning phase, when we started in around 23 January, we were taking around 40 minutes. Now we are able to complete within 15 to 18 minutes, sir.
Wonderful.
This is Dr. Jyotina. I have one question. Can you hear me?
Yeah.
Yes, we can.
Yeah. So you've done it in pediatric patients also, this procedure, or?
No, ma'am. As of now, we didn't get, because in AIG we have only all the gastro and adult population. So pediatric wing is not well established. So we didn't have any pediatric patients as of now. Yeah.
But data is there? Data are there for pediatric patients or in literature?
It is there, ma'am, but very limited. Most of the cases,
Okay.
most of the literature is only on the adult malignant cases only. Yeah.
Okay. Thank you.
I have a question for Dr. Jayanthi. Fantastic
Yeah.
talk, and as you can see, the audience is well engaged and asking a lot of questions. So this is a hot topic. We're expecting a few posters and presentations about this from India to the upcoming SNMI annual meeting in New Orleans, actually, because I reviewed some of those abstracts. So looking forward to it. No procedure is without complications, though, and so I was curious, what's your approach to I know you had a very good slide that if you don't prepare to fail, you're preparing to fail, or that was a very catchy slide. But complications will happen, unforeseen. And have you had any, and what's your philosophy on managing those complications?
Yes, sir. We had 2 cases of hematemesis, like hemoptysis, and 1 case of pneumothorax, where ICD insertion was needed. And in these 2 cases, we have given Tranexa like 1000 mg over a short period. So, which was patient was able to tolerate with that thing. And yeah, otherwise no major complication which we were not able to manage. Such kind of things didn't happen. But yeah, definitely, sir. Every invasive procedure is associated with risk. We went with a single poke itself. Even then, all these complications are there. So yeah, we can't avoid that thing.
And does your setup go with the automated co-registration of the PET and the CT data,
Yes.
or is it manually done?
No, sir, it's automatic co-registered data, sir.
And okay, so I think that's another, and it allows for automated insertion of the needle as well, because I think in the US the regulations require um, some more things for automated needle insertion or something
Here
like
it
that.
is not automated needle insertion. It will only show the trajectory, point of entry, and it will fix the bush in such a way that we will go exactly uh, in in such an angle which is premeditated at the time of our plan. Otherwise,
Okay.
insertion, taking the sample, everything has to be done from ourselves only. But 70% of the help we take from the biopsy, because angulation, mediolateral, all those things will be prefixed with the help of robo.
Yeah, because more than a decade ago we tried this approach with PET CT guided breast biopsies in the PEM, positron emission mammography setup. Didn't take off much in the US, but that was more because of financial constraints and regulatory issues than the accuracy. So I'm glad. Any thoughts of doing that in India? Because a majority of breast biopsies also come back negative, and that may help as well.
Yes, sir. Definitely it will be helpful, but we are not getting much breast cases because it's a gastro center. So that's the
Oh,
reason.
okay. So it's a referring physician issue. Sounds
Yes.
good. Wonderful talk. Thank you.
Thank you, sir.
There is one more question in the chat box from Dr. Halkar. Which PET CT and model is there? Resolution recover recon available and used? Oh, sorry. Which PET CT and model is there? Resolution recover recon available and used?
We have Siemens Biograph Horizon, ma'am. Coming to resolution, recover, recon, I don't have much idea about that. I need to go through that thing. Yeah.
The model number, probably we can actually get the specifications there.
Yes, yes, ma'am. Yeah.
Resolution recovery software will help you even detect smaller lesions with a better SUV values.
Okay,
And
sir.
most of the
Third
modern
party,
systems have the resolution recovery, Siemens as well as GE.
like it is inherent within the thing, sir, or it's a third party thing where we
No,
need to
it is inherent in
Okay.
the later models.
Okay.
Yeah, but they may charge you a little more for the license to reconstruct it in a different way or something. A related question: do you have 4D gating with respiration for the thoracoabdominal interface lesions like lung base or hepatic dome?
Yes, sir. Our PET CT is equipped with that. Yeah.
And do you use it?
Sir, they are using that thing for RT planning. We did not
Yeah.
much use for our purposes because we didn't face much difficulty till now. Maybe as sir said, if you are planning for any smaller lesions at the time, maybe whether it will be helpful or not, we have to go through that once.
Yeah, I think if you get down to 5-6 millimeter lesions, you'll require the resolution recovery, reconstruction algorithms, and potentially respiratory gating for better targeting. So,
Yes,
awesome.
sir.
So with the new PET scanners, with the digitals and other thing, most of them are digitals, and I think now the resolution, CT resolution, has increased so much. I'm just speaking for the biopsy, not for the diagnostic purposes over here. I think these newer software manipulation may be a little bit not needed just for the biopsy purposes, because the resolution with the new scanners are getting so much higher, and I believe that I may be wrong in future, but hitting a 3 millimeter nodule into the lungs is going to be a nightmare. So I don't think that hitting a 8 millimeter or 1 centimeter would require the resolution recovery. That's what I think. And with the total body scanners in 5 years' time, may be much cheaper. Who knows?
Yes.
Yeah. Hi, this is Chitra. I just wanted to first of all, awesome talk. You know, regarding all the new PET-CT system or from Siemens or GE, just ask them to always, they are pretty good at it, ask them to provide you a data sheet which has all the bells and whistles in there. Like they can microscopically go down and give you all the parameters, and it comes in like just 2 pages. So that will be you can ask that. So you'll have all the resolutions and pixel size and whatever you need.
Sure, ma'am. Yeah.
And thank you, Chitra, for your message. I
No,
would try to be
no,
there.
no, you have no choice. I don't give you a choice.
All right.
Please, please, your presence is everyone's present, but you are so special to us.
No, thank you, Chitra, for the confidence. I really appreciate. It's been a little while since I've been to the meetings, but this year I'm going, so hopefully.
Okay, Amol, we're gonna get the drums, okay?
Drums for Dr. Gupta. All right.
Yes.
You're in charge, so you should arrange it.
No, I'm just a co-pilot.
All right, guys. Thank you for a wonderful talk. We, Uma, I think we can conclude.
Sure, yeah, absolutely. So it was really wonderful. I mean, even a person who was totally lay person like me was totally into it. It was such a thorough and meticulous talk, and I think it has stirred a lot of discussions, which is a true reflection of the quality of the talk. And thank you very much, Dr. Mohan, and thank you all for sparing your time to be part of the series. Night
Thank
and
you for
good
the
day,
wonderful words.
everyone.
Thank you for
Bye-bye.
all the audience. Like I got your inputs so that we can better ourselves with these things. Yeah. Thank you all.
Amol,
Thank
can you share the number, please, of Dr. Jayanthi whenever you get
Yes,
it?
we will. Yes,
No
we
rush.
will.
Thank you.
Okay.
Yeah,
Sounds good.
he'll
All right.
put
Thanks.
his email in the chat box. I think that's j.mohanroop@gmail.com and mohanroop.j@aighospitals.com.
Thank you.
Thank you. Okay. Bye.
Thank
Thank
you.
you.
Bye-bye, everyone.